Hyalual.
Hi, my dear colleagues. It's nice for me today to be with you. Actually, it's not that much typical way of communication for me. I mean, online only. But because of this epidemiological situation, we must stay home to be safe. And also, we must stay home to show an example for our patients. And this is a good opportunity to refresh our skills, our knowledges. And today we're gonna talk about chronic dermatosis, such as acne, post-acne treatments, and rosacea. Speaking about acne, why do I think it's really important question? Because unfortunately, approximately 30% of our clients in age between 20 to 36, 37 years old suffers from rashes. And we can treat them because of, for example, jawline, because of lips, but in this case, we must know a lot about acne as a disease. So, acne by Fitzpatrick, it is a multifactorial disease, chronic, which is characterized by appearance of comedones, opened, closed comedones, pustules, papules, and so on. Speaking about the age of the patients, I would say, mostly it's about teenagers, but patients from 20 to 30, 36 also suffers from acne. Besides, we must remember about a late manifestation of acne. And yes, we have definitely such psychological aspects of acne. For example, most unemployed persons suffers from acne. This is by statistic. Main aspects of acne, psychological aspect, leads to emotional disorders, depressions, and so on. Acute inflammation leads to cosmetological problems such as hyperpigmentation, such as scars. And when this inflammation become a little bit more, not that much acute, we say it's inflammation, it's chronic process, and this process leads to premature aging of skin. If we will speak about pathogenesis of acne, this is very important moment. I would like to describe this process very easy. So, of course, the application point of acne, it's sebaceous glands. In sebaceous glands formates sebum or sebum secretion. This is such a lipid substance. Normally, sebum glands formates sebum. Sebum evacuates through the pore, through the skin pore to the skin surface, distributes evenly in the skin surface to what? To reinforce main function of our skin, protective function. And sebum protects our skin from high or low temperature, from different chemical substances or physical structures. So this is normally. In case of patients with acne, we have the significant increase the amount of sebum secretion. Besides, the chemical composition of sebum in case of acne differs. So linolenic acid is impaired in the amount in sebum of such patients. Also, the process of evacuating of sebum from sebaceous glands through the pore to the skin also impaired. So, as the result, we have accumulation of sebum in the sebaceous glands. Till now, till this moment, I described you the process of formatting comedones, opened comedones, closed comedones, opened comedones like a blackheads, you know that, closed comedones such like a whitehead. If we will add to this process presence of Propionbacterium acne, we will have what? Inflammation, and we will have formation of pustula and papilla, and further. Should I continue, or we have problems with connection? Everything's great. Okay. So, and if we will see these elements of rashes as the red one, like a papilla. And all these links of pathogenesis ruled by 5-alpha reductase. This is the hormone-dependent receptor. That's why if we can see severe forms of acne, I guess it will be a young man. But if we see a young girl with the severe acne form, so we must think about, I would say, hormonal disorders. Actually, when we speak about hyperandrogenism, in case of women, we can divide it into 3 groups: cosmetic, gynecological, and metabolical disorders. So cosmetic is acne, alopecia, seborrhea, hirsutism. Gynecological, this is the endometrial hyperplasia, menstrual disorders, anovulation, and polycystic ovarian diseases. Speaking about the metabolic disorders, upper body obesity, insulin resistance type 2 diabetes, and hyperlipoproteinemia. The main elements of acne is comedones and pustules. In this case, we will have definitely the process of inflammation and the process of increasing level of pro-inflammatory interleukins, especially when we deal with popular form of acne. And as you understand, I will explain later a little bit that axillary derm helps us, because of succinic acid present, to minimize the level of these interleukins pro-inflammatory, which significantly, I would say dramatically, increase in case of acne. So this is the picture with clinical manifestation of acne. First picture, this is normal follicle. We can see sebaceous glands. We see the normal amount of sebum. The second picture, this is the pimple, closed comedone. Closed comedone, it's so-called white head, but without any inflammation still. So we see sebaceous gland, we see accumulation, of sebum. Opened comedone, picture number 3. We can see black head. I would say that this black head, we see this color of this element. It's black not because of environmental factors. It's black because of melanocytes. Papule, picture number 4, we can see inflammation caused by Propionbacterium acne. And in case of pimple, we see this significant inflammation, And we see in the picture number 6, node. Also, when we palpate node, it's pretty density. Assessment of severity of acne. Of course, we must estimate our patient before the treatment. It's actually not that much difficult. We have 3 forms of acne: mild, moderate, and severe. Speaking about comedones, in case of mild form, less than 20. Speaking about papules and pustules, less than 10, 15. And no nodes, no scars still. In case of moderate, comedones from 20 to 100, papules and pustules from 15, 20 and more. And we still don't have, in case of moderate, scars and nodes, density nodes. In case of severe acne form, comedones more than 100, papules and pustules more than 50, and we can have, in this case, scars, we can have nodes. General ways of treatment of acne patients. First, it's diet. This is very important factor, diet, because milk and sugar can cause the significant form of acne. Actually, milk and sugar sounds great, but it's really significant. Some of us, we treat topically. We can even make isotretinoin scam, but sometimes we forget about diet. What else can lead to severe acne except milk, except sugar? Coffee. In this case, you can advise to take to this patient decaffeinated drinks. Yeah, hot meal, spice meal, fat meal, and so on. Avoiding comedonogenic makeup. It's also very important, because in case of this comedonogenic makeup, we can make occlusion microfilm in the skin surface, and we can make this process harder. Hygienic skin cosmetic. Yes, of course, this is obligatory, because our patient must use this cosmetic even when they have very good prolonged remission. Topical and or systemic therapy. Yes, and correction of post-acne complication if necessary. Also, generally principles of acne treatment. So, in case of mild acne, we will make diet, cosmeceuticals, yes, topical therapy, not in case of mild. Moderate diet, yes, cosmeceuticals always, topical therapy always, and usually, so typically in case of moderate acne, I do not offer systemic therapy, isotretinoin. But in case of severe acne, we use diet, cosmeceuticals, topicals, topical therapy, and isotretinoin as well. So, to make this summary, mild, this is topical therapy only, moderate, topical therapy, and oral therapy, I mean doxycycline. My favorite doxycycline is minocycline, because if we deal with acne, we must take doxycycline at least 4 or 5 weeks. In this case, we must think about the how to say, how pure this product, how pure these drugs. And minocycline is okay in this case. Severe acne forms, topical therapy, oral therapy, and isotretinoin. So post-acne changes, they usually happens when we deal with severe acne form, when this process is pretty prolonged, when the therapy was not effective, and because of, for example, not correct treatment of pimples or something like this. So, symptomacomplex post-acne, we can divide into 4 types. This first is erythema. This is process when we see the red or with violet component spots caused by impairment microcirculation. So it's vascular spots. Sometimes there is no need to evacuate this pustula because it's no pustula now. But we can see these spots, vascular spots, and this is pretty common cosmetic disorder, cosmetic problem. Dyschromia or hyperpigmentation, scars, atrophic, hypertrophic scars, and enlarged pores. Speaking about enlarged pores, even when we deal with the patients which nowadays not suffer from acne in prolonged remission, their pores will be definitely enlarged. So, and we must manage expectation of our patient, speaking about pores, because unfortunately there is no need one procedure, even heart ablative procedure, to minimize this pore, the size of their pores, for example, for 3 or 4 months. Even RB or CO2 laser procedures, even TCA needle depth peel, they can minimize the pore size, for example, for 3-4 weeks. But of course, it's not indication for such a procedures. So we must explain our patients that enlarged pores, we must minimize its size using the cosmeceuticals at home at least twice a day. I mean lotions with low pH, I mean acid pads, and this is a pretty effective method. So this pore enlargement caused by accumulation of sebum in this sebaceous glands, and this accumulation leads to enlarged pore. This moment significant impair the skin texture, and this is pretty common problem. Speaking about erythema, these vascular spots with violet components we can see in the case of papilla form acne. Even patient cannot evacuate this papilla. Definitely these patients will have such problems because of microcirculation, because of prolonged compression of these vessels. Post-inflammatory hyperpigmentation. Usually happens after papilla, again, papilla form of acne. In case of 4 and third 4 phototype by Fitzpatrick, and because of chronic inflammation, so long period of disease. By different literature, we can estimate that from 30 to 90% of our clients suffers from scars in case of acne disease. And of course, scars, post-acne scars, it's very popular aesthetic problem because, of course, nowadays we have plenty to do with these scars. But we should remember that scars, the regions of connective tissue with no hair follicles, with no sebaceous glands, these regions of connective tissue, from the point of view of histopathology, open for UV radiation, for example, and this is the also significant problem, speaking about inflammation. Types of scars. Speaking about hypertrophic scars, we have approximately 3 ways of types of these scars and hypertrophic scars. Ice peak, rolling, and box scar. The deepness of these atrophic scars also varies. This is how it looks like, and ultrasound examination. Ice peak box scars, and rolling scars, hypertrophy scars, and keloid scars. Of course, dear colleagues, keloid scars, it's really subject for further apart webinar, agree, because post-acne correction. Of course, speaking about post-acne changes, we should remember about laser energy-based device procedures such as laser ablation, ablative procedure. It's very good procedure to make more even skin surface, and of course, depending on the type of scar, the technique and the parameters of laser treatment also will vary. And I want to speak about redermalization. So typically I explain for my patients with acne that redermalization for them, it's really purpose therapy, because it's like a 2-in-1. Why? Because this therapy of injecting xyloderm, of injecting product with succinate acid and hyaluronic acid, acts on each link of pathogenesis of acne and post-acne. Remember, post-acne hyperpigmentation, we know action of succinate acid to tyrosinase. Scars, we know how works succinate acid and hyaluronic acid with skin structure, yeah, and vascular spots. Later, I will explain one more time about about growth factor, vascular growth factor, and it's, of course, it's acts on each link of pathogenesis, and extra, it's like a basic therapy for anti-age treatment. And that's why we can say that it's really 2-in-1. Of course, peels, mechanical dermabrasion, dermal resurfacing, and photorejuvenation. So this product, Xyloderm, this is the skin enhancer. This is not filler. This is not cross-links product. One more time, it consists of high molecular weight hyaluronic acid and succinate acid. From product to product varies only concentration of hyaluronic acid, and we have 1.1, 1.8, and 2.2 percentage of hyaluronic acid. Succinate acid always stable, and it is 1.6% in each product. So sometimes my colleagues ask me, why do we need such many types of redermalization products? Because at least we have 4 main morphotypes of our patient. But speaking about even one patient, we have different anatomical zones, anatomical areas. So, for example, we have very delicate periorbital zone, and we have, in case of acne, middle face with post-acne scars, with post-acne changes. And definitely we understand that this different area needs different products. And that's why I would say that we really need to inject for almost each patient succinate acid, but with different concentration of HA, we can safely inject in the different areas. And of course, the main, the key difference of this product, if we will compare with biorealization, it's of course presence of succinate acid. Yeah, because biorealization, it's also very good procedure, but the only indications for biorealization is to rehydrate skin and to make skin thicker. If we want to provide such effects as antioxidant effects, such effects of to increase microcirculation, yeah, to minimize level of pH acidosis on the tissue level and in the level of cell. Of course, we can expect such effect only after injecting product with succinic acid. Speaking about treatment of post-acne changes. Of course, you understand that if we deal with such post-acne changes as, for example, hyperpigmentation and enlarged pores and erythema, actually we do not need that much concentrative product. Why? Because the skin of acne patients, I would say, the skin of such a patients pretty oily, not that much dehydrated, and that's why for us it will be enough, not that much concentrated products. So it's very good opportunity to start with H&S or 1.1 Xyloderm. The second procedure, 1.1, in case of atrophic scars, for example. The third procedure is 1.8, and the last one, 2.2. Atrophic scar is the only indication, the only aesthetic problems. If we speak about atrophic scars or about post-acne, it's the only problem when we inject 1.8 and 2.2. Why? Why do we need this? Because when our skin surface suffers, we need more concentrative product to give to the skin this substance to rebuild the structure of the skin. And besides, typically, the situation of atrophic scars, typically middle face and lower face, but not periorbital area, when we afraid to inject, for example, 2.2. Yeah. So in case of hyperpigmentation, in case of dyschromia, we can start from Electri. Remember, 0.5% concentration of HA. Second procedure, H&S. Third procedure, H&S. And the last one, fourth procedure, 1.1. You remember, basic course of procedure, not in case with acne patients, but normally, it's 3 procedures. I recommend to inject acne group of patients not 3, but 4 times. And also, I recommend to combine this treatment, redermalization, in case of acne with peel. I will read your questions. Can I use immediately 2.2? Well, in case of post-acne changes as a hypertrophy or hypertrophy scars, yes, you can just immediately. First appointment, 2.2. In case of dyschromia and in case of erythema, for example, actually there is no need to inject this product because in case of hyperpigmentation and erythema, the point is in the succinic acid, not in the concentration of HA. So in case of acne scars, if you don't have any products, you can start even from 2.2. But you know why it's so useful to start from this low concentration of HA. For example, from H&S, from 1.1, because we can achieve lymphodrainage effect. H&S it's also redermalization product, but for very sensitive skin for patients with rosacea. And concentration of HA in product H&S 0.9. The concentration of succinic acid is stable and constant, and it is 1.6. So, in case of enlarged pores, first procedure H&S 0.9 concentration. Second procedure, second appointment 1.1 Xyloderm. Interval between procedure 2-3 weeks. Please make at least 2, 3, 4 procedures. Erythema, first procedure, also H&S, second procedure, and third and fourth procedure, 1.1. We do not need, in this case, 1.8, 2.2. Scars, you can start from H&S or 1.1, second procedure 1.1, third 1.8, and fourth 2.2. In case of acne scars, you can make with your needle regular fan, as you, for example, make it with a cannula, regular fan technique. The point is the depth of your injection must be really intradermal, really superficial, so that you can see the color of your needle. So if you see the grayness of your needle, it's okay. It's pretty uncomfortable for patient, but from the point of view of good results, it's very good. We must tear these collagen and elastin fibers to stimulate in further. Morphological element of congestive character. We can inject not just right into this papule, but around. And remember, when you have a lot of pustula, you should not inject just right into the epicenter of this pustula, of course. This is typical situation of papilla. So, in this scheme, you can see the typical deepness of your injection in case when you have atrophy of tissue. So you can make like a parallel line. You can make 90-degree lines to make like reinforcement of dermis. And the point is, don't forget, be as well superficially as you can. And so I can show you the scheme. If you see this atrophy scar, your needle goes a little bit down, and under this scar, you make fan technique with your needle. You tear these fibers, of course, unfortunately, with vessels only, also. And this technique, patients suffers after ecchymosis, of course, as you understand. And your depot of product, your papilla of product under this atrophy scar. So, types of atrophy scars. Ice pick is the most deep atrophy scars because it affects the dermal layer, and this is the problem. Actually, sometimes this type of scars also problem because if we will treat this patient with ice pick scars with a laser, it's not that much easy to reach the how to say, the depth of this scar because it's pretty deep. Rolling scars, it's more superficial scars, so they can affect dermis, they can not affect dermis, and this easily, much easier to influence on this type of scar. As well, box scars, they also can affect dermis layer or cannot affect. Advantages of redermalization for the treatment of acne. So, for me, very important benefit of this way of injection treatment, it's action on all links of pathogenesis of acne. And, for example, when we have acne, active form, papilla form, we have inflammation, we have significant increasing of level of pro-inflammatory cytokines. When we inject succinate, we minimize this level. when we combine with peel, Hyalual peel, for example, any of these 4 peel, but clarifying is the best for this problem. If we will combine with this peel, we will minimize the appearance of new comedones, papule, pustule. Also speaking about post-acne changes, xyloderm help us to minimize hyperpigmentation. This working with vessels, with microcirculation by definite growth factor, yes, vessel growth factor, and working with skin structure in case of scars. And of course, we don't forget this, that redermalization is basic anti-age program treatment. So for patients, it's like a 2-in-1. Of course, we don't forget that in case of how we estimate our patients, whether it's mild form or severe, of course, we should not forget about drugs, about doxycycline or isotretinoin sometimes. How we should finish our procedure. So, actually, speaking about combined technique, I want to add some sentences about this. So, I can make, in case of acne patient, typical redermalization, ordinary redermalization. So, application of anesthesia topical with occlusion, yeah. Then using of decasan, gorosten, chlorhexidine, and then injection. So, for example, we already have chosen the concentration, the technique we provide redermalization, and after this, I apply 1 layer of peel. And after 1-2 minutes, I clean up my peel with the help of cotton pads and chlorhexidine or decasan. So antiseptic without alcohol. In case of, for example, if I will make only peel without redermalization, without injection, I can use just ordinary water. But in case of combined treatment, injection and peel, I clean up the skin, patient's skin with decasan or chlorhexidine to minimize the risk of what? Of secondary infection. Or I can just make redermalization in case if necessary, in case we don't need, for example, peel in this case. I use after redermalization Prophylax. Prophylax, this is the professional care, injectional care. Actually, some physicians use Prophylax even after energy-based devices procedures, because Prophylax minimize very good sense of irritations, sense of itching, because after redermalization, you know definitely that after redermalization, just immediately after, we can see this redness. Patients can feel this itching effect, and Prophylax will minimize it. And of course, Prophylax will minimize the risk of secondary infection as well. Don't forget to give safe sun and to apply safe sun for patients. This is the results before, after, our favorite pictures. The patient with multiple atrophic scar. Also, we can see erythema in case of these patients. So, it was provided redermalization with scar subcision with a needle, yeah. 2.2% xyloderm, and it was provided Acupulse device photothermolysis procedure. So we see this combined procedure. Actually, xyloderm, it's very good to combine with something, with, for example, with energy-based devices, with PRP, with whatever. For me, it's also, for example, my favorite protocol before botulinum therapy. Because of the level of pH of this product close to physiological, we can really easily combine with another ways of treatment, aesthetical. And speaking about energy-based devices procedures, why it's really necessary and useful to inject before axillary derm? Because with the help of succinic acid, we can control this inflammation, predictable inflammation after energy-based devices procedures. This is pictures, before-after pictures of patients with post-acne scars, atrophic scars. It was used 1.1% axillary derm with standard interval, and we see this good results. The next patient with pigmentation, with hyperpigmentation, with erythema spots, and we see the results after Sesderma pills, retinoic pills, and after using of axillary derm 1.1 with 2 weeks interval. Our next discussion is rosacea. Rosacea is also a very important topic to discuss, because speaking about our patient after approximately 30, 40 years, 30 plus years old, at least 25, approximately 20-25% of our clients suffers from rosacea. Rosacea is also multifactorial chronic disease, and the application point of this chronic disease is also sebaceous glands, and the point is that suffers sensitivity of the capillaries of the dermis to heat. Speaking about the pathogenesis of rosacea, all these processes starts from inflammation, which caused by toll-like receptors, TLR2 receptors of keratinocytes. Because of ultraviolet exposure, because of low or the other way around high temperature, because of heating of the modex follicularum. Also, this process can be caused by neuropeptides or stress mechanisms. And after this, after reaction of toll-like receptors, we can see significant increase of MMP2. MMP2 is matrix metalloproteinase. This is such a zinc-dependent proteins. Everything's okay. Zinc-dependent proteins, which significant destroy first glucose aminoglycan structures. It's collagen and elastin fibers of our dermis. And as you remember on our basic training, it's approximately 30 type of MMP, but only 2 of them, MMP2 and MMP9, very aggressive to our collagen and elastin fibers and very pathogenic. And succinic acid successfully minimized the level of MMP2 and high molecular weight HA, successfully significant decrease the level of MMP9. So in this case, when we inject, in case of rosacea, a significant increasing of MMP2, yes, if we inject product with succinic acid, we will achieve the result of minimizing this MMP2. It's very important. Also, let's see this process rosacea from the point of view of vessel tone. So as you remember, rosacea mm, typically situated in the center of the face, and typically this is like angioneurosis of region of nervus trigeminus. And this is the point. The vessels in this area are prolonged, enlarged in case of rosacea. These vessels doesn't react on temperature. I mean, they are enlarged, and that's all. And when we inject axillary derm with succinic acid, we achieve the effect of vessel dilatation. But in this time, after this, we achieve the effect of vasoconstriction and prolonged vasoconstriction. And why it's very good for rosacea vessels? Because vessels of patients with rosacea react on something, and it's very good training for this enlarged, prolonged enlarged vessels. Besides succinic acid, speaking about hemoglobin, succinic acid increase the likeness of hemoglobin to O2, to oxygen. And this is a very good point for enhance oxidation and vascularizations of these tissues in case of rosacea patients. That's why when we treat patients with rosacea with succinic acid, we can what we can promise them. We can promise to minimize this erythema level, to minimize new papulas and pustulas. What trigger factor of rosacea? Of course, it's a high temperature, smoking, taking alcohol, spicy and hot food, and the modex folliculorum. Okay, subtypes of clinical stages of rosacea. First subtype, it's erythematosis teleoangiectatic rosacea. When we see erythema, when we see teleoangioectasia. The second subtype, papulopustular rosacea, when we see papulas and pustula. Third subtype, it's phematose or hypertrophic rosacea. For example, rhinophyma. Subtype 4, ocular rosacea. This patient suffers from dryness of eye. And the fifth one, granulomatous rosacea. And be careful, this form needs very good differential diagnosis with another chronic dermatological diseases. Diagnosing rosacea, primary signs, of course, it's transient erythema. Second, it's prolonged erythema, papules, presence of papules and pustulas, and telangiectasia. Linear telangiectasia or star-like telangiectasia. Secondary signs, it's itching, dryness, soreness, burning, feel of burning, paresthesia, plaques, edema, ocular rosacea, skin lesions or peripheral areas, so extrafacial rosacea. Differential diagnosis of acne and rosacea. So, speaking about comedones, in case of acne, we will see these comedones, but none in case of rosacea. Papules and pustulas, sufficiently in case of acne and in case of rosacea. Nodulus on the skin, acne present, rosacea none. Keloid scars can be present in case of acne and absent in case of rosacea. Spider veins or telangiectasia in case of acne, none. In case of rosacea, sufficiently pronounced. But you should remember that it's not 100%. Why? Because in case of acne, after not correct evacuation of papilla or pustula, we also can see the telangiectasia. Additional methods of analysis. In case of rosacea patient, biochemical blood test, yes. Skin scarping to identify the Demodex follicularum. Helicobacter presence, Helicobacter pylori presence test, thyroid gland function, diagnostic biopsy in case if necessary, in difficult cases. Differential diagnostics of acne and rosacea, like summary. So key symptoms of rosacea: erythema, redness and red spots, hot flashes, and that's why we must differentiate also in case with late manifestation of rosacea, this symptom, hot flashes, we must differentiate with climax. Visible blood vessels and veins, flushing and feeling hot on the face, and eye redness and dryness. Key symptoms of acne: presence of comedon, blackhead or whitehead, papules, pustules, red inflamed or not inflamed, also nodes, ulceration, cyst in case of severe types of acne, and abscesses. Not obligatory, but still. So general recommendation for such patients with rosacea, of course, is avoid these trigger factors, such as hot meals, such as spice meal, smoking, heating procedures, and so on. Using of sunscreen SPF 30, but I recommend more than 50. Stop using exfoliating products. And this is the point, because sometimes when we deal with such patients with rosacea for the first time, sometimes we're trying to use peels and all these energy-based devices, procedures when we typically use in case of acne patient, but we are understand that it's not correct. We cannot use all these methods for such patients. We must remember that this patient suffers from irritation, suffers from a really significant dryness of the skin. The protective function of skin of such patients really decreased. And apply soft emollients with ureage. Treatment approaches. First, systemic therapy, antibacterial therapy. Again, doxycycline. It's common with the acne ways of treatment. My favorite, minocycline, at least 4 or 5 weeks. 5-nitroimidazole derivatives, such as metronidazole. Synthetic retinoids, isotretinoin, again common, like in case in acne. Topical therapy, metronidazole. I like Rosamet. I don't know whether in your country you have Rosamet or not. Azelaic acid, this is pretty mild acid, this is available for rosacea. Clindamycin, sodium sulfoxylamide and sulfur. Tacrolimus, pimecrolimus, tretinoin and benzoyl peroxide as well. But be careful with benzoyl peroxide in case of rosacea patient, because it can be burning significant in case of this patient. Cosmetological procedures. So, of course, common ways of treatment. We can advise such patients laser procedures. We can advise EPL therapy. For example, I recommend in case of erythema, it's better to use EPL, not laser, but EPL therapy, like BBL. Yeah. In case of patient has a linear telangiectasia or star-like telangiectasia, it's better to use laser, for example, neodyme laser. Stimulation current therapy, chemical pills, but mild pills, such as enzyme peel, very mild peels, not to irritate that much their skin, and of course redermalization. Because of this action of vascular growth factors to tone of these microcirculations vessels of rosacea, we can achieve this result. We can force these impaired vessels to react on our succinic acid and to achieve this effect of vasoconstriction. And I will repeat, it's like a two-in-one procedure. It's like a basic anti-age therapy, and it's like a therapy which acts on each link of pathogenesis of rosacea as well. So, in the case of rosacea patient, we should finish our procedure with prophylaxis as well and with safe sun. The technique. So, if you remember, basic technique of redermalization is micropapilla technique and papilla technique. If you want your papilla will disappear up to 1-2 days, the size of papilla must be really small. For example, if you treat periorbital area, you should make micropapilla. In the lower face, in the middle face, you can make regular papilla technique. Speaking about rosacea, of course, you can also provide a regular basic papilla technique, but it's better to remember that rosacea is angioneurosis of nervus trigeminus, and you can situate your papilla like nervus trigeminus situated. With micropapilla technique. The first procedure 1.1% axillary derm, second procedure 1.8, and third procedure 2.2. Amount 2 cc. This is the before-after picture. This is our results. Rosacea, papules, and pustules form, and it was provided 4 procedures with 2 weeks interval, 1.1% concentration. We see significant results. So, our practical part. This is the patient. You've seen these pictures before, after, with post-acne scars, with atrophic scars, applying of anesthetic with the occlusion, applying after this peel, clarifying peel, injection of axillary derm in the lower and middle face, perfaskin, xella shape, to make more evenly skin surface. After this, we continue the procedure with axillary derm, and the end of procedure is a wow mask to minimize the irritation after procedure, post-procedural redness. After this, we should spray prophylaxis. Another video I will show you. This is basic redermalization. So, speaking about the portrait of patient, remember we have 4 main morphotypes of patients. This girl looks like tired morphotype with edema, with ptosis of corner of the mouth and eyes, tendency to swelling, wrinkles, acne, and post-acne changes. So the concentration 1.1% of Xyluriderm, it's a very good solution to start with. Of course, you remember Xyluriderm consists of 1.1% and high molecular weight HA and succinic acid. And succinic acid provides such effects as mechanical support, antioxidant support of tissues, working with microcirculation, minimize the level of acidosis, regulates the cellular energy exchange. And hyaluronic acid gives us the mechanical support and restores water balance. Of course, patients with acne doesn't suffer from significant dehydration. So in this case, 1.1 will be enough. So this is how we choose our products. Next session, we can choose a little bit more concentrative product. So basic technique, intradermal injection with micropapilla. So we are cleaning the patient's skin. Apply anesthesia. Actually, it's up to you. Sometimes you should use a plastic to make occlusion. Sometimes it's not necessary. Like in case of our anesthetic, 15-20 minutes. We are cleaning up the rest of anesthesia. And we are providing redermalization. Start from periorbital area, from medial to lateral part. Micropapilla technique. The injection is really superficial. It will help you to minimize swelling and bruising. Remember that after 1-2 minutes, your papilla will be a little bit larger. Don't forget upper eyelid, then forehead, middle face. In the forehead or middle face, you can make this papilla, if you want, a little bit larger, but not in case of periorbital area. Also, don't forget, we do not inject 2.2 in the periorbital area. Approximately 1-3 millimeters diameter of your papilla. And post-procedural care, we will spray Prophylax to minimize itching and redness. So this is the typical protocol of basic redermalization. Xyluriderm, Prophylax. Actually, if you want to use Prophylax, the patient will be with this redness 40-50 minutes. If you will use Prophylax, the post-procedural redness will disappear after 15 approximately minutes. Don't forget safe sun and cosmeceuticals to reinforce this effect of redermalization. Why we can inject 2.2 around periorbital area? This is you are texting me the questions. We must not inject 2.2 in the periorbital area because we remember about action of succinic acid to absorb the water, and this concentration 2.2, it's pretty hard concentration, and it's very good, for example, to achieve lifting effect. It's very good to make more even middle face after hypertrophy post-acne scars, but it's too much for periorbital area. We can achieve the effect of swelling, edema effect in the periorbital area, especially when you see before the procedure, if you see the conturation of malar fats, I guess you can achieve pretty significant edema with 2.2. So actually, even 1.8% concentration, you can inject this concentration in the periorbital area. But in case of, for example, muscular or small wrinkled morphotype, but not in case tight morphotype or deformative morphotype, when we see the significant problems with the microcirculation. So, of course, you can combine. For example, we have syringes 2 cc and 1 cc. So you can choose 1 cc 1.1 and 1 cc 2.2 and combine for one patient. Anesthetic cream, you have seen in the video our Hyalual anesthetic, so you can apply wherever you want, whatever you have. Cannot see the video. How do you advise these questions or convince your patients to take different types of product for atrophic scars during your consultations, especially those with budget problems? Do you promote them in a package? So, speaking about budget is pretty tricky questions, of course, always. As you remember, in case of erythema, in case of hyperpigmentation, of enlarged pores, you can choose Electri H&S in 1.1. It's a little bit cheaper than, for example, 2.2. Do I promote them in a package? Sometimes. Well, for someone, it's really a very good point to buy, let's say, buy 3 or 4 procedures. For someone, it's not the reason. So it depends on my patients. We only have 2 cc of the injection, not 1 cc. So, okay, you can choose, for example, for first appointment, you can choose 2 cc of 1.1. In case of necessary, you have your own clinical thinking, and you can next time you can choose according protocol, or just up to you. You can use 2 cc of 1.8% in case it's necessary. So it's not a problem. Do you still have questions for me? Text me something. I hope you will have possibility to look this webinar with sound. I hope. It was really a pleasure for me to communicate with you. I hope you successfully practice in future. Thank you. Thank you.